So now I'd like to introduce Dr. Charles Stanley, who is the father of hyperinsulinism, in my opinion, and I embarrass him every time he does this talk about this. But now I'm like maybe even older than him because I've been I'm teasing. He is so great and such a fantastic, brilliant man, and it's such a pleasure to introduce you, and we have so much to learn from you.
Thanks very much, Julie. You always embarrass me by saying how old I am. I think that's why she makes me do history, because she thinks I remember all this stuff. I'm just going to give you a little bit of the background on hyperinsulinism, talking about the history, because history is important. You have to know your history so you don't repeat the same mistakes. And you see where we're coming from, but that also gives you some projection and prediction of where we're going in the future. And the good news is that the trajectory of what we know about hyperinsulinism has been going up like a rocket. So we're sort of accelerating to understand the disorder and to cure it. That's what we're all looking for, right? So hypoglycemia actually is a disorder that we didn't know about in medicine until people discovered insulin back in 1922 for treating diabetes. And one of the first patients who ever got treated with diabetes got an overdose and had hypoglycemia, and it was the first time when the doctors went in to see this patient. He was climbing the wall, and they recognized that this was hypoglycemia. And the first time in pediatrics, really, that we began to recognize hypoglycemia is about 1954, way before I was born. And this was described by Dr. McQuarrie from Minneapolis, who was the president of the Pediatric Society in the US. And he gave a presidential address about this disorder because presidents of societies don't usually talk science, but he thought this was so important to make people aware of, because he'd seen children who'd had spontaneous hypoglycemia and had suffered permanent and severe brain damage because of delays in diagnosis and inadequate early therapy. One of the patients that he described, actually these two children shown on this slide, this is a brother and sister who had idiopathic spontaneous hypoglycemia of infancy, and they had to get treated with pancreatectomies. You can't quite see it, but they have pancreatectomy scars, railroad tracks on their bellies. Now, this is their family. This is the older brother and the younger sister, and they had three cousins who were also affected. And this made Dr. McQuarrie think maybe this is a familial genetic disorder. And it turns out that's exactly right. Here's how that family looks when we recontacted them about 8 years ago. Here's the brother and the sister. And in yellow are all of the people in 4 generations of this family who have hypoglycemia, including, interestingly, their mother, who didn't recognize that she had hypoglycemia until she was 80 years old and had a hypoglycemic seizure. And it turns out that their hyperinsulinism, they have hyperinsulinism, and it's linked to the hexokinase gene on chromosome 10. This is a very rare form of hyperinsulinism, but it opened the way to think about genetics in this disorder. So McCory's concern back in the 50s was this a genetic disorder, that it caused brain damage because of delays in diagnosis and inadequate therapy, so it was preventable, and that the treatment options in those days were restricted to either taking out the pancreas or the pancreatectomy or treating with glucocorticoids, which are really not very effective. And the next advance was actually the next year in 1955, when Dr. Cochrane from Great Ormond Street Hospital in London described patients who had hypoglycemia that was induced by protein feeding, or especially the amino acid leucine. This was leucine-sensitive hypoglycemia. And this he thought was very important because it said there was a relationship between amino acids and glucose metabolism, and this should be of great interest not only to clinicians but also to basic scientists. And this is the first demonstration, and we learned it from Pediatrics, that amino acids also play a role in regulating insulin secretion. It's not just glucose. And the first application of the immunoassay for insulin that was discovered by Burson and Yalow, who got the Nobel Prize for this work, was to show that insulin levels were increased in children with leucine-sensitive hypoglycemia. It was the first demonstration that hypoglycemia in this disorder was caused by insulin. And the first treatment for this disorder was described in 1964 by Dr. Drash from Pittsburgh, who showed that diazoxide could control hypoglycemia in some of these children with leucine-sensitive hypoglycemia. Now, unfortunately, this has been about the only treatment that's been available for this disorder. These from 64 to, I can't even count that. Paul, you do the math. 51 years, right? So in 1975, we finally figured out that we shouldn't call this idiopathic hypoglycemia anymore. It's congenital hyperinsulinism. It's really due to insulin. And this was described by Maury Heyman and Tony Pagliara in St. Louis, and I was involved in that with Lester Baker here and Ainsley Green from London. And we figured out the simple criteria for diagnosing the disorder: hyper, elevated insulin; hypo, too low ketones; hypofatty acidemia; and hyperglycemic response to glucagon, an inappropriate good response to glucagon injection. And then in 1981, we finally figured out that this is not an embryologic disorder of overgrowth of insulin cells. It's not necidioblastosis. This was done by Dr. Jaffe from Pittsburgh and Dr. Rahier from Belgium. And then the group in Paris with Dr. Rahier pointed out that there are two types of hyperinsulinism. There's diffuse hyperinsulinism, where the islets look perfectly normal but make too much insulin, and the only abnormality is that they have some cells with big nuclei. But there's a form where the islet cells are overgrown and give you a focal lesion. That's the problem, and taking out that focal lesion, just snipping it out, and Dr. Adzik will tell you how to do that a little later, you cure the disease. In the 1990s and 2000s, an important development was the establishment of centers of excellence for treating hyperinsulinism, beginning probably first in France and in England, where there are now 2 centers, Israel, the US, where there are now 2 centers, here in Philadelphia, and Cook Children's Hospital in Fort Worth. Centers developing in Germany, and now Australia and China are working on developing centers of excellence for these children. And here's our team in Philadelphia that includes obviously Dr. De Leon, who leads the program, Dr. Body, who's our pathologist, Lisa States, who does our PET scans, Dr. Adzik, who does our surgery, and a whole team of nurses that you're meeting this morning, geneticists, and here's Kara Snyder, who works with me in the lab. Now, this is our bragging slide about where all of our patients for surgery come from. This is actually a little outdated. This is only 390 patients that we've seen. I think Scott says we're up to 470 some odd. And they come from all over the US and from across the world. Now, in 1995, we first recognized that there are two genetic forms of hyperinsulinism. There can be recessive disease that Dr. Eller talked to you about, where the parents are carriers, and then you can have a quarter of the children being affected. Or you can have dominant disease, where the disorder is passed from grandmother to son to granddaughter in a vertical pattern. And we've now recognized that there are at least 10 different genetic defects in hyperinsulinism, 10 different proteins that can be involved. Dr. Allard talked about SIR1 and KIR6.2 that make up with a potassium channel, and this is the most severe kind of hyperinsulinism because these patients don't respond to diazoxide. But there are now 9 other different genetic forms of hyperinsulinism. And each of those disorders has a slightly different phenotype about whether they'll respond to diazoxide, whether they respond to protein. Some are even triggered by exercise. And then there's this focal hyperinsulinism that you heard about, where you can cure the disease by just taking out this little tumor of overgrown beta cells. And this occurs when the child inherits a mutation on the father's chromosome and loses the normal chromosome allele from the mother. And when you lose the mother's portion of chromosome 11, you also lose these growth controlling genes, so it causes the beta cells to overgrow. So it's this second random hit in the embryo that causes focal disease. And the genetic testing is very useful because it predicts focal disease with a very high degree of accuracy. If you inherit a recessive mutation, you've got a 97% chance of having a focal lesion. So it's very, very predictive, and if it came specifically from the father, 97% likely it's going to be focal, and your confidence in that is 93%. So it's very useful doing this rapidly before going to surgery. And the second test that's helpful for focal lesions is being able to image them with fluorodopa PET scans, which was introduced actually by Timo Tonkoski from Finland just in 2006, so just 10 years ago. Here's an example of a focal lesion shown on PET scan. You can see the pancreas very faintly floating through the abdomen as you turn around, and here's the focal lesion. It's just like having GPS for the surgeon to find that lesion and snip it right out. And here's what the lesions look like at surgery. Dr. Adzik will talk to you a little bit more, but here's this little focal lesion. It's smaller than a half a fingernail. And that would be very hard to find without the PET scan. And this has made a big difference in the outcomes of patients who have to go to surgery, because in the focal cases, we can get an absolute cure in 95% of the children. Whereas for diffuse disease, surgery doesn't cure patients, and it needs some more work. In 2015, the Pediatric Endocrine Society published guidelines to help pediatricians and neonatologists diagnose and manage children with hyperinsulinism. And importantly, we were able to make this available free online, so it's easy for physicians and families. Yeah. We've come a long way with treatments. Dr. DeLeon is working on developing a new treatment derived from lizard spit, which works in animals, and now there are other new future treatments in progress. Long-acting octreotide, Diva's GLP-1 antagonists, sirolimus, companies like Zoma and Xeris that are working on new treatments. So the future for the family organization for you all obviously is advocacy. You have to teach people about this condition and how to work on removing barriers to treatment, helping to raise research funds, networking with other families, fundraising. All of these things are important. And it's particularly important because, as this lady says, it's a very rare disease. It doesn't have a cure, it doesn't even have a spokesperson. But it has spokespersons. Here are two children with focal hyperinsulinism who've been cured by surgery, and their mothers, and these are the spokespeople that have to work on the future of hyperinsulinism. Thank you.
Thank you so much, Dr. Stanley, and this is a great opportunity to ask questions. You'll have a lot of opportunities throughout the 2 days, but if anyone has one now.
Yes.
I don't think I actually need that thing. All right. Part of what I see is like diabetes. We're so comfortable with insulin. On the opposite side here, getting glucagon seems to be part of the issue. Is there part of the treatment issue that there's not long-acting glucagon, or it's not soluble enough, or it's not, it's degrades too quickly? What's the issue on getting to the alpha cell as opposed to the beta cell?
Well, part of the problem has been that glucagon has been available since the 1950s, but it's very unstable in solution, so you can't use it in pumps. You can't run around with a glucagon pen that you can give yourself little mini doses. And there's the Xeris company is working on a stable, soluble form of glucagon that could be used in pumps. So that's one of the possibilities in the pipeline. Very important.
Hi. Our son has ABCC8 recessive from both of us, diffuse. So from what you put up on the screen, does that mean that any child he has a 97% chance of having focal?
No.
Okay, good.
No. It takes two events to have a focal lesion. You have to inherit the mutation from the father, and then a random event has to happen in the embryo that causes an overgrowth. And the chance of your child, your son, inheriting with two mutations, the passing on mutation is 50-50. Actually, in that case, it would be 100%. But the chance that there's going to be the second loss of heterozygosity event is about 1 in 500 or more. So the chance of having a child with focal disease is only about 1 in 500.
Good morning. First, let me preface this. I promised Ashley I would preface it by saying we have quite a while before we have to deal with this. But looking at the genetics, it appears like her offspring has about a 50% chance of carrying the HI-HA. What do we know about diazoxide in pregnancy? Because everything I've read says it should not be taken during pregnancy, so.
Yeah, we've had that issue come up in a number of young ladies and families with dominant hyperinsulinism. And as the general recommendation has been to try to not give the diazoxide during the pregnancy because it gets across the placenta and can suppress insulin in the fetus. And usually during that time you can find other ways of trying to manage the hyperinsulinism, but that takes, we don't have ideal ways of doing that right now.
Any more questions?
Hi. I'm a carrier of this gene, the mutation. Does that mean that my siblings are also carriers?
Well, possibly. So the question is, when you have a family with a child with hyperinsulinism and you find the genetic mutation, what do you do not only for the next generation but for the previous generation? And we talk about doing cascade testing of the family to see who might be a carrier and whether that might be important for them in family planning. Yes, and so that's the kind of testing that Dr. Ellard talked about, of doing extended family testing. Yeah.
Hi, Julie said it is not a dumb question, so I hope this is not. When a woman had diabetes during pregnancy, can that be a sign that the children will have this disease or not at all? Because usually when they are born, the baby has low blood sugar and then the doctors confuse. They
Yes.
say, no, it's just because of the diabetes that you had during pregnancy or whatever, I don't know.
Yeah, so one of the markers for most of the children with hyperinsulinism is the tendency to be large birth weight, because insulin is a very potent fetal growth factor. And mothers with diabetes during pregnancy with high blood sugar, the response in the fetus is to make more insulin and to be large. So a large birth weight is thought about as possibly diabetes. So there can be a confusion sometimes. So the rule is you have to test all the babies that are large for dates, and you have to think about not only diabetes but also the possibility of a genetic form of hyperinsulinism.
So, but can this be considered one of I don't know how to say. Yeah.
Well, so a risk factor for the baby to need to be tested to make sure it's not a permanent form of hypoglycemia. But I thought your other question was whether mothers carrying a baby with hyperinsulinism had any signs of abnormalities in their own blood sugar, and the answer is no. That the baby's blood sugar and insulin secretion is separate from the mother's.
Hi. I had a baby just 67 days ago, and I had this gestational diabetes. So I had a large baby, and he also needed oxygen when he was born.
Right.
So for the first month, more than 1 month, I was told that his hyperinsulinism was transient, that he would resolve it by himself. And now we're waiting for genetic testing, which they only drew blood from him, so they never asked either me or the father to give the blood to the genetic testing. And they're telling us it's not really important to have the genetic testing because it's not going to affect the way they're going to manage it medically. So, and they keep telling us it still might be something that will disappear.
Yeah. So transient hypoglycemia can occur in infants of diabetic mothers, and generally doesn't last more than a week, rarely more than a couple of weeks. And how do you know that it's permanent rather than transient? The longer you go that it's still there, the more likely it is not to be transient. And once you get out beyond 2-3 weeks, then you really start having to think about genetic. So you're how many days? You're a month and a half out. It's smelling more and more like it's not transient. Yeah. And the other issue, when you're doing genetic testing, you test not only the baby, but you also get a blood sample on the parents, because once you find a mutation, then you want to know the parent of origin. So you like to have that in hand.
So the blood test that they're having my son, it's not going to give us much information because they don't have our blood samples, is it?
Well, they may need to come back and get that, but if they find that there's a mutation in the baby, then that gives you some prediction about where you're going and whether this is going to be
Portugal,
permanent.
I'm from Portugal. They tell us that the results, we won't have the results in less than 6 months. What happens to my baby in the meantime?
But you talk to Dr. Ellard, and it should be.
We'll make sure that you get a fast test. We'll talk later today.
Yeah.
Hi. So I've been coming here for 10 years, and it's amazing. I'm blown away by all of this every time, but also about the fact that we're, in this room we're not an anomaly, but in the world we are. But I just felt the need to mention, while all of the experts are here, especially the ones working in genetics, because I feel like we've mentioned this before to CHOP, but in addition to the fact that we're both carriers of recessive genes, Larry's an identical twin, which makes us that much more of an anomaly. And I just sort of wanted to offer up my husband's brother and his family, if that can be, just because they have children who do not have HI, and if that can in any way for the research be useful. It feels like it's weird enough that he's an identical twin in the rest of life, but in this context, it just seems like it could be relevant. So if you need somebody who's a carrier who is an identical twin, we've got one. So.
Yeah, thank you.
Hello. Our daughter will be 2 next month. We thought, I guess it was the transient type. She's still on diazoxide, where I believe she was tested for the 5 main types. I was trying to see, is there any new genes they discovered recently, or anything else they do testing for?
Yeah, well, so we're now up to, I think, 10 plus syndromic forms. I think there are probably close to 20 different genetic loci involved in hyperinsulinism, and the standard testing is 4 common genes, and then the extended is now 10, but there are genes out there. One of the issues is that in many of the diazoxide responsive patients, we don't find a mutation, and we're not sure whether that's genes that we haven't discovered yet, or mutations that don't show up in the bloodstream. So stay tuned, and that the answers to that may be coming out. Yeah.